cerebral palsy and the orthopaedic considerations. This is a rather large topic, so I've gone through a brief overview of all the principles involved and some of the orthopaedic matters available, but not gone into any great depth about the specificities of some of the surgery. So cerebral palsy is defined as a disorder of movement and posture due to a defect or lesion in the developing brain. It's important to note that it is not a diagnosis per se, but a heterogeneous collection of clinical syndromes grouped because of their similarities. And it's also very important to note that the cerebral lesion is static, but the musculoskeletal pathology is progressive as a result. There's multiple different causes identified. These can be broken down into prenatal, and postnatal causes. And they all involve some sort of insult to different parts of the brain. We'll get to that in a moment. Prenatal causes being a placental insufficiency, presumably leading to hypoxia. Toxins, including drugs of dependence and alcohol. There's recently been described there's a much larger genetic component than was once thought. And your torch conditions being toxoplasmosis, cytomegalovirus, and herpes. Rubella, that's right. Perinatal causes, so premature delivery, any other reason for hypoxia, infection, kernicterus, and any hemolytic disease of the newborn. Postnatal causes shown to be infection and trauma. Again, classically, there was a lot of talk around inappropriate delivery techniques and that leading to hypoxia and leading to cerebral palsy. That's been shown to be somewhat overrated compared to the influence of genetic factors, which is shown to be, despite a lot of the improvements in the delivery process, the incidence of cerebral palsy remains static, or indeed is actually increasing as we're able to sustain the lives of babies born more prematurely. So if we look first at demographics, approximately 2 per 1,000 live births across all populations. 50% will have normal intelligence, and about 25% will be able to self-support as an adult. Cerebral palsy can be broken down by the type of motor disorder involved, and then indeed by the limbs involved. These types of disorder relate to exactly where the lesion in the brain is located. So a spastic palsy will be in the pyramidal system or the motor cortex. Athetoid relates to extrapyramidal basal ganglia. Ataxic conditions occur from lesions in the cerebellum and brainstem. Then you have your rigid disorders, which are slightly less common, and then of course mixed. In terms of the limb involvement, they talk about a monoplegia, which is rare, likewise a triplegia, and then your more common hemiplegias and diplegias, as well as quadriplegia, being the most severe. The clinical features of cerebral palsy are dependent on multiple different factors, most notably the severity of the neurological lesion involved, the location of the lesion, as we just saw, and the age of the child at presentation, which does as well relate to the severity of the lesion. This means that there is a spectrum of clinical findings dependent on these three factors. In the most severe setting, there can be an absence of normal reflexes of a baby, such as blinking and sucking reflexes, persistence of abnormal reflexes beyond the expected age, such as Morrow's reflex, delayed motor milestones, and I've got the standard milestones in there just for reference, as well as any noted gait disturbance. I was going to be asked that. Oh, that's right. Yeah, that's right. you make a movement as if they're falling through gravity from a sitting position backwards, and they throw all their limbs out straight. In addition to that, because we've talked here about the orthopaedic clinical features, but because this is primarily a neurological condition causing this, there could be another spectrum of neurological issues, including epilepsy, speech and hearing difficulties, visual defects, feeding difficulties, drooling in the more severe end of the spectrum, and then learning and behavioural problems. On examination, there can be abnormal posturing. With a hypotonic cerebral palsy, you got a hypotonic slump, an extension of the lower limbs. Standing, often they're noted to have a crouch posture, which is flexion at the hips and the knees, and indeed an equinus deformity of the ankle, which we'll get to in a moment. Spastic posturing of the lower limb, which includes the pelvic obliquity, and indeed this relates to whether it's a hemiplegia or a plegia, and loss of lumbar lordosis. Some of these changes, including loss of lumbar lordosis, can be related to the neurological lesion directly, or may indeed relate to the posturing required to compensate for the lesion's problems it's causing more distally. In terms of gait, a patient can have athetoid or ataxic movement. Neuromuscular factors involved as well. They may have a positive Babinski sign. And then we'll get on to the deformities in a moment, including your equinus and fixed flexion deformities of the knee and hip. So this I found a good way of explaining it, and the way that the primary neurological pathology relates to the orthopaedic pathology that we see in practice. So the growth of skeletal muscle depends on regular stretching of the relaxed muscle, undergoing during the process of normal physiological loading. With spasticity in cerebral palsy, muscle obviously does not relax, meaning that you do not get this regular stretching on relaxed muscle. And indeed, because of the functional deficits, these babies and children have reduced activity because of weakness and balance issues, which again compound. This leads to, in the initial setting, dynamic contractures of muscles because of the spasticity, and these are correctable, and so the muscle may be stretched to its normal length. Once contractures actually start to form, though, a fixed deformity develops, and you're unable, even under anaesthesia, to correct the flexion. This then leads to stage 3, where the spasticity and contractures have actually caused secondary bone changes because of the chronic forces applied. Most commonly, these are your medial femoral torsion and lateral tibial torsion. Where a muscle group and indeed a limb are at along these 3 stages of deformity indicates which level of treatment or what treatment option. Moving on to the orthopaedic management of these conditions, obviously what we need to realise is that cerebral palsy, it's a complex condition, and multimodal care is required, involvement from paediatricians, treatment of the patient's any other sequelae of their neurological lesion, being learning difficulties, be it behavioural issues, the functional demands of the patient, and indeed the parents in caring for them. And we have to realise that what we're doing in orthopaedics is treating the sequelae of the neurological lesion. We're not actually treating the lesion itself. And as was specified earlier, the lesion is going to be static, but certainly the orthopaedic issues that arise are continuous and progressive and degenerative, which makes it somewhat of a moving target, particularly in growing children, about how best to manage them. Many of the operations historically that are used to treat cerebral palsy were developed for the management of polio. The differentiating factor being that polio is a static condition and one of hypotonia, whereas cerebral palsy results in problems that are spasticity, indeed causing a progressive condition. If we relate this back in broad terms to the diagram demonstrated there, stage 1, where you have dynamic contractures, this is where things like physiotherapy need to be involved, orthoses are certainly of use. The use of botulinum has been shown to have good effects in some situations. And in terms of surgical management, you have your selective posterior rhizotomy, which involves there's a extensive laminectomy approach involved to sever some of the posterior columns to treat some of the spasticity. But this can be a fairly invasive procedure with variable results. Stage 2, where you have fixed contractures, but not yet any bony deformity. This timing is critical for surgery, and indeed results again have been shown to be quite unpredictable. Given that there is often multi-joint involvement and indeed secondary compensation by muscle groups and joints, there has been a lot of controversy around whether staged or single procedures are in the patient's best interest. Some papers report this concept of birthday syndrome, where patients with cerebral palsy are ending up having operations almost every year. On the one hand, treating a changing condition in a single joint, and the other trying to compensate and treat several joints over a period of time, versus doing a single operation with multiple. In stage 3, where you do have secondary bone changes, that's when we start looking at correctional osteotomies to correct some of the problems involved. One of the most commonly recommended procedures are tendon transfers. So I've listed some broad principles there of what you're trying to achieve when performing any tendon transfer. Now looking specifically at the lower extremity. So again, the age of surgical intervention is critical. Gait evolves into the adult pattern by about the age of 7 years. And intervening too early means that recurrence and further deterioration will occur in paediatric patients, and indeed, although the recommended age for intervention is in the early school years, so that the 5 and 6 year olds, gait deterioration does then secondarily occur in adolescence quite commonly. A thorough preoperative evaluation is required, as indeed it is with anything, and this involves evaluation of multiple joints. Notably, there correcting a tendo Achilles contracture in the presence of a tight hamstrings will result in a persistent crouch at the knee and a calcaneus. And a lot of papers do actually state that a little bit of equinus with the TA is actually better than a result with a calcaneus gait, which is more difficult. The role of gait analysis has shown to be very, very important in recent years. And there's a number of, certainly at the kids, there's the gait lab. Specifically looking at swing phase foot clearance and the foot progression angle. Intervention. Breaking it down into the different groups within the different manifestations of cerebral palsy. With your hemiplegic patients, these are divided to 4 groups as demonstrated there. With the problem essentially starting more distally, and then as we proceed through the groups becoming more medial as well. So in group 1 you'll have the mild foot drop gait, for which an AFO is very effective. Group 2, when they do actually have a proper equinus gait with a contracture of their gastrocsoleus or isolated, one of the two, where stretching casts can be used. Botulinum AFOs again. Group 3, where you've got involvement with the knee and medial hamstrings and quadriceps, just misspelt there, apologies, is when you start looking at procedures like a gastroc recession, medial hamstring lengthening, and indeed that often has to be performed along with a distal rectus femoris transfer if there's concurrent rectus femoris spasticity as well. Group 4, where you're getting hip changes, this is when you need to start looking at lengthening of the psoas muscle, and then if there are any secondary bony deformities that have formed, external rotational osteotomies, along with all the management options listed above to treat the more distal. With a spastic diplegia, most actually achieve good function, and this is when you do run into a lot of secondary bone torsional problems, and these are usually more medial issues, looking at the hip flexors, the adductors, and the medial rotators. Looking at the specific procedures listed before, one of the most common being lengthening of the Achilles tendon. This is actually described in several of the papers I looked at to be quite an overused procedure. And indeed, they point out that a little equinus is better than calcaneus when it comes to gait. It's important to perform the Silverskoid test, which is most sensitive under general anaesthesia. And this looks at the amount of dorsiflexion at the ankle with the knee in full extension and then the knee flexed to differentiate with whether the contracture is in gastroc or as well in soleus. Gastroc obviously crossing the knee joint and soleus inserting proximally into the tibia. If indeed there is an isolated gastroc contracture, then gastrocnemius recession is a preferred procedure, and there are a number of different techniques described for lengthening of the Achilles tendon. Your considerations when choosing one of these techniques are, one, the ability to perform the correction to an appropriate length and not over-lengthen, which is described as significant risk when using any percutaneous technique surgeon. And then your open techniques, which have obviously greater risk of infection and greater risk of wound issue and scarring. Varus deformity of the foot is far more common than a valgus deformity, and it's tib post that's usually responsible for this. Interestingly, tib ant can also be responsible for varus deformity, the difference clinically being that deformity will be present in both stance and swing phase of gait with tib when tib post has the spasticity, but in tib ant will only be present during the swing. Management of this, there are options for lengthening of the tendon in addition to tendon transfers. Again, there are various other procedures described for correcting valgus deformity. Again, lengthening, fusions at the midfoot, as well as opening wedge osteotomies. Moving on to knee flexion contractures, this is the classic crouch, posturing or gait that we see in CP kids. Surgical lengthening of medial hamstrings can be performed, but the neurovascular bundle has to be considered in severe contractures, and the amount to which you can release the hamstrings is dependent on particularly if the deformity's been there and static for a long period of time. A stiff knee gait can arise if there's rectus femoris crowspasticity, as I said before, and this is when a rectus femoris transfer is. Hip flexion contractures often are not as a result directly of the neurological lesion, but arise as a result of the knee and ankle issues. At a very basic level, if you imagine someone with an equinus posturing of their ankle and a flexion deformity of their knee, they're going to have to keep their hips flexed during standing to maintain a center of gravity. Hip flexion contractions are obviously looked at with Billy tests, and psoas lengthening can often be performed. More severe bony deformities can arise. These include actual hip subluxation, as is shown in this case study of a 12-year-old girl, as well as medial torsional deformities. And this is when rotational osteotomies, as shown here, are indicated. This child's had bilateral external rotational osteotomies performed with a distal femur, in addition to multiple other procedures. And this leads down to hip reconstructive surgery in the severe settings. there shown with a blade plate. And because of this deformity and because this leads, similar to DDH cases of an ill-formed acetabulum, pelvic osteotomies are also required. Moving on to the upper limb. So again, a full evaluation of the patient is required, particularly looking at sensation, which is somewhat more important in the upper limb in fine motor movement rather. Electromyography, it's controversial whether this does actually have a role. Ascertain specifically which muscles are involved. And your principles of managing any lesions in the upper extremity and indeed the lower extremity, one, to define goals and look at what exactly you're intending to achieve and whether the patient and usually their parents are realistic about what's going to be achieved. To restore the normal position of joints and posture, and then to rebalance and minimize the chance of recurrence of contraction. There's a child pre and post bilateral surgery. Specifically at the different joints. So shoulder, the most common deformity is an internal rotation and adducted posture. Botox can be used, and particularly with any lengthening or injection, you're looking at subscap and pec major. And in very severe cases, external rotational osteotomy can be performed of the proximal humerus, but this is much less. The elbow, static and dynamic flexion contractures are usually, so a contracture will have a static contracture or a fixed flexion deformity, but in addition to that, there will be a dynamic flexion. And this, similar to the knee, the amount of release that can be achieved is very dependent on the neurovascular bundle. Being a static contracture for a period of time. There's multiple procedures listed or described for the contractures of the wrists and digits, and I didn't get into this great length. Often you'll have a wrist flexion deformity with or without pronation and ulnar deviation. And any lengthening or transfer procedure have to consider the role of the flexors in their relation to their control of the digits. Often these children end up with swan neck deformities of the digits as a result.